Good evening. Thank you for coming. On behalf of the Gold Humanism Honor Society, we would like to thank you for coming tonight to our first annual Last Lecture series featuring Dr. Fitzgerald. The Gold Humanism Honor Society is a national honor society whose aim is to honor medical students, residents, and role model physician teachers who've been recognized for demonstrated excellence in clinical care, leadership, compassion, and dedication to service. The UC Davis chapter has been active since 2010. This last lecture series is one of many efforts of our society to bring to the forefront the ideals and embodiment of humanistic service. The idea of the last lecture comes from the lecture and book by Dr. Randy Pausch, who was a professor at Carnegie Mellon University. Dr. Pausch was diagnosed with terminal pancreatic cancer, and before he left his post as a professor, he delivered one last lecture to all of his students and faculty about chasing childhood dreams and making the most of your life. That lecture went on to become a YouTube sensation and a best-selling book and has sprung up many events in the same vein. Tonight we'd like to recreate a similar concept, and we asked Dr. Fitzgerald to come speak on the prompt, if this was your last opportunity to speak to medical students and residents, what would you like to say to them?
Dr. Fitzgerald is an internist and professor of internal medicine at UC Davis. She was awarded her medical degree from UC San Francisco in 1969, was board certified in internal medicine in 1973, and has been teaching medical students and residents ever since. In addition to her renowned abilities as a teacher and as an astute diagnostician, she has also written articles on a wide variety of topics in medicine and has been recognized as a master of the American College of Physicians. Dr. Fitzgerald has been a distinguished career in service of others and is nothing less than a treasure. She was selected overwhelmingly by the class of 2014 to give this particular lecture and we are incredibly fortunate to have her here with us tonight. So without further ado, I would like to introduce to you Dr. Faith Fitzgerald.
The last lecture, it's kind of interesting. I'm going to start by telling you about another event. It happened 20 years ago, but it sort of set me on the path of trying to tell you the sort of thing that the last lecture is supposed to. And I have here a souvenir from that event. It's a t-shirt. There. And it was a party thrown on what was then a grassy knoll, which is now the pavilion, by the house staff and students on my 50th birthday. And that's what the F3 is for on the t-shirt, because I usually use F2. It's less hard to write. And my students and house staff, all of whom were at this outdoor barbecue, told me that I had to have a midlife crisis now because I was 50. First, I thought that was very optimistic, just because midlife, 50 centenarians. But secondly, because I didn't know how to do a midlife crisis. I'd heard about them. But it was mostly about men. And they got muscle cars, but I'm not obviously a man. So what I wanted to do was ask them if I had to go out and get a new boy. And they said no. They said, this is how you have a midlife crisis. And what you do is think of all the things that you might have done and all the turning points in those decisions that have taken you down the road, and whether now, at midlife, would be that time to make another choice from those things that you did not choose before, but which attracted you. Now, all of you have multiple talents and multiple interests. And the question is whether or not, at some point in the future, you will think that maybe being an entomologist would have been better. I don't think so, but that would be your choice. So I said, oh, That's how. Then I woke up on the morning of my birthday, which I had taken off, my birthday present to myself, and I thought, I have to do something this morning. I promised the students and the residents I would. That's right, I must have a midlife crisis now. And I remembered what they told me, and having done that, I did my midlife crisis. And I remembered that I had, from childhood, wanted to be a doctor. So that was step number one. Now, I don't know why. There were no doctors in my family. There was no big event. There was no revelation. I just always kind of wanted to be a doctor so far back as I can remember, even though I didn't know what I was talking about. And then when I got to medical school, I wanted to be an internist. And that's it. And this didn't happen. There were no roads not taken. So now what do I do? That was a pretty short and boring midlife crisis. So I asked another question, and it goes back to, why as a small child did I even think I wanted to be a doctor? And I think part of it, in retrospect, and I was contemplating this 20 years ago, was that I was born in 1943, and I was in elementary school up through the late 40s, 48, 49, and it was before Jonas Salk. And there was a lot of polio going through our country and the world. And as I went, for example, from 3rd to 4th grade, I noticed after summer vacation, returning to this same class, that people were missing. Little people that I had played with before, and I was as little as they were at the time, so it was kind of sad. And I'd ask, what happened to Johnny or Nancy? And they'd say, well, don't worry about it. They'll be okay. And it turned out that some of them had caught polio and were now paralyzed. And some had died of other infectious diseases. Now, it wasn't a whole bunch, but nonetheless, that struck me as wrong somehow. The big scare for me, because children are, at least I was, of the idea that they're more or less invulnerable, when a classmate took me home to meet her mother. And we walked into her house, my classmate, and she said, "Mommy, we're here." And all I heard coming from the room where Mommy evidently was this sound. And my friend took me by the hand and sort of went into the room, and her Mommy was in this gigantic tube. She was in an iron lung. And then it struck me that mommies could get sick. And that was infinitely more scary, infinitely more important. Because mommies were the best thing there were. And even they could get sick, even though they were grown-ups. And then about that same time, that same period, when I was mulling the sort of catastrophes that could happen through disease, although I didn't think of it then, my grandmother gave me a book. And I couldn't have been more 6 or 7 years old. It was in 3 volumes, actually. And I discovered this man who couldn't make a living as a doctor. Actually, he'd studied to be a doctor and then went on into ophthalmology as a subspecialty, somewhat unusual for his time, and nobody wanted to come see him. He had a wife, he had a family, he had to earn some money. Apparently his biggest fee ever as an ophthalmologist was when he put down a neighbor's old dog. And so he started to think what else he could do, what other gifts he had. It turned out he had a gift for telling stories, for writing, and he thought of this man. This man is Dr. Joseph Bell, and he was Arthur Conan Doyle's teacher of surgery at the University of Edinburgh School of Medicine. And Dr. Bell was a remarkable fellow because of his keen intellect, but also because he had these preternatural, extraordinary powers of observation. He used to walk into a waiting room in a clinic, for example, and be able to tell by looking at somebody where he had come from, how he got to the waiting room, what his previous job had been, what his current work was, and what was bothering him. That's before actually examining the man. And Arthur Conan Doyle thought that he was one of the greatest solvers of puzzles that he had ever met. Now, he was not sparked into doing that same thing, but he thought maybe I can earn a little cash by writing about somebody like Joseph Bell. And so he wrote a story. And the story he wrote was the first Sherlock Holmes. Who's watched House? You know, that also is a gift of Arthur Conan Doyle. It's a permutation of Holmes. Holmes' House. The two are totally different. Don't watch it anymore. He's a bad man. But Sherlock Holmes has been the major model of detective fiction ever since. And as a child, I thought, boy, wouldn't that be great if I could do that? Because disease is a crime. And it robs you of the things you can do, and sometimes it murders you. And here's this guidebook as to how to find out things that can help either punish the malefactor or, better yet, save the potential murdered victim. And I learned from Sherlock Holmes how to look at the clues, how to think about them, how to gather the necessary information, and then go to the scene of the crime, which in our case is the patient, who's both giving the story of what happened, as well as those clues as to the evidence on his or her body of what happened. And if there's family there, they're the witnesses to the crime and can give us more information about what happened. And then I thought I'd go to medical school because I knew such a thing existed, and they'd teach me about all of the suspects, and most of them in my mind at then were infectious diseases, but also about things like cancer and heart trouble and high blood pressure. They're all thieves and murderers. And then I would do a forensic trial, which I thought would be mostly microscopy. It turns out now to be this, but same idea. You're trying to track down the murderer, and you are looking at the modus operandi of the suspects. And then, quite illegal, I think, in our country, I'd just execute them. And in the first Sherlock Holmes story, which was a novel called A Study in Scarlet, and then published first in 1887, so an old book, Sherlock Holmes says to his friend and companion, Dr. Watson, let him, on meeting a fellow mortal, by which he means the detective, meeting a fellow mortal, learn at a glance to distinguish the history of the man and the trade or profession to which he belongs. Well, I kind of knew that from the stories that came later. But what struck me in retrospect was that thing, fellow mortal. In spite of being categorized, both in the original writings and in House, as sort of a mean and uncaring man, who was a drug addict concurrently, by the way, that the words fellow mortal meant that he recognized that the victims of the crime were suffering. And I tell you that things like pity or solace or sympathy are not the same as what we mean when we say empathy. Empathy is the ability to witness someone else's suffering, and the word patient means one who suffers, and say to yourself, that could be me. I am a fellow mortal. And for that reason, I thought maybe he's kind of a hidden empath, Sherlock Holmes. He was mean to criminals, but not terribly mean to people who were in trouble. Well, Dr. Watson heard him say that, and he replied, what ineffable twaddle, which I think is the Victorian equivalent of bullpucky. So, next step, having established the possibility, at least in my own mind, that what I wanted to be was a medical detective rather than a criminal detective, because I'd had really no experience with crime, but I had with sickness and suffering through my friends and that mother, and discovered that I'd made the right choice, because the solving of puzzles still is my greatest joy. I love being an internist because it's the diagnostician. It is the medical detective. It is that individual who's supposed to take all of the pieces that are now subspecialized and put them all together so that perhaps you can find some common theme within them that allows you to come to a diagnosis. And then I learned from my patients how joyful it was. There was a man admitted here, well, perhaps 15, 20 years ago, who was a diagnostic mystery. And he was on my service. He'd been seen by everybody. His story was that about 2 weeks before he came to our emergency room, he developed a bad headache and a somewhat stiff neck. But he was a manly man, so he didn't do anything about it. And he just got better. A week later, however, one of his friends said, "You look funny." "Why do I look funny?" "You're yellow." He developed jaundice. And it turned out, when he came to the emergency room, not only was he jaundiced, but he had renal failure. And he was feeling weak, and he was anemic, and they did labs. We always do labs. And his labs showed that he had inflammatory hepatitis, renal failure, very low platelets in his blood, and an elevation in muscle enzymes. Well, everybody came to see him. The hematologist did, the hepatologist did, the renal people came to see him, and they were all each working on the low platelets or the liver or the kidneys, and I didn't know what it was he had. And so I read all of the things that these consultants had done, and it all had been thoroughly explored. They did wonderful histories, including social histories and family histories and the exploration of what toxins he might have been exposed to in his work. So we had an occupational history, a travel history. Did he use any herbs or alternative medicines that might be hepatotoxic and lead to all of this thing? Nothing, nothing, nothing. I'm thinking, what am I going to do? And I walked in, and he's sitting in bed looking yellow. And I said to him, you have all of these things going on, and I don't know why. And I'm going to try to ask a question that nobody else has asked. And I was desperately thinking what that question might be. And it occurred to me that he'd had an occupational history, but not everybody has just an occupation. Some people have hobbies. And in the course of their work with hobbies, they might be exposed to some toxin or other. So I asked him, I said, "Do you have a hobby?" He said, "Yes." I said, "What do you do? What's your hobby?" He said, "I shoot rats." "You shoot rats?" "Yep." And then he told me that every Saturday and Sunday he'd go out to the rice paddies north of Sacramento because they were full of rats. And he'd shoot them dead with a gun. And I asked him, I said, "What do you do with the rats?" He said, "Well, I go and I get them and I hang them up by their tails on a local fence." That was his hobby. And I knew what his diagnosis was. Boy, did I luck out. Anybody? He hadn't been bitten by any rats, I asked him that. But he was wandering around in water that was occupied by rats, and then he was picking them up. And he'd get some rat stuff on him, including pee. And what he had was leptospirosis. Now, it's a small picture and not a very good one, but it's a spirochete. And it's very common. There are multiple types of it. And one of them is called Leptospira ictohemorrhagica. Hey, icto, yellow, hemorrhagica, bleeding, low platelets. And most people get it when they get peed on by rats. He would go right into a waterbed occupied by rats. And there must have been leptospira there everywhere. And it gets in by the mouth. And usually it causes an initial headache and stiff neck and fever. Most of the time, people get away with it. But he didn't. After about a week of feeling better, the classic course of this disease goes, then the liver begins to go. There's leptospira in there. And there is renal failure associated with it. And it's associated very often with very low platelets. And I lucked out. I felt so proud of myself. And we treated him with antibiotics and he got better. It's called Weil's disease. And it can kill you. But he was a sturdy guy. I did advise him before he checked out that he shouldn't go rat shooting anymore. And he said that he wanted to do more than ever. because they had made him sick. And he was going to go out, and he actually said this, and do rat revenge. Well, within maybe another 10 years, there was a woman admitted to OBGYN, and she was in her late 60s, and she had a terribly swollen belly, which the obstetricians, and this was pre-ultrasound, pre-CAT scan, thought might be a big ovarian tumor. And I was the attending on the general medicine consult service, so we were asked to see her to put her in shape for this exploratory operation. And I went into her room, and she looked kind of like this. This is not a picture of her, but might have been. She was very swollen in her face, and her arms and legs and her belly was tremendous. She had everted her umbilicus. It changed from an innie to an outie from the pressure. And she looked terrible. And within about 3 minutes of talking back and forth, we were all laughing at her. And it occurred to me that was an odd reaction to someone desperately ill about to risk her life in an operation. And why was it so funny? Because she started actually to proposition one of the residents. A good-looking young man, I grant you, but still, it seemed inappropriate at the time. And she was disinhibited about her tumor, about her humor. Yeah, she would say things that normally people don't say, and they were funny. And by the way, she talked like this. And I'm looking at her and I'm thinking that I've heard of something like this, that looks something like this, or at least I've read about it, never seen it before. And I went out to talk to the OB and I said, you know, she might be really profoundly hypothyroid, because there's this thing called myxedema wit, which is where the profound thyroid deficiency leads to brain dysfunction and particularly disinhibition, so you just say things that turn out to be really funny. The hoarse voice. She didn't have pitting edema that accounted for her swelling, I thought. She had myxedema, which is firmer. And so it was quite logical to assume that whatever was in her belly wasn't just fluid, but that's what it was. It was a tenacious fluid, and I know that because the OB said it couldn't wait and took her to operation. She survived. But he said there was this stuff coming out of her belly which was kind of like proteinaceous. And that's myxedema fluid. So we drew the thyroid functions after the procedure, came back with profoundly low thyroid, very high TSH, and had to supplement her with thyroid hormone, working up very, very slowly. A woman came in 3 times, and she was in her mid-70s. And she had to come because every now and again she would begin to hemorrhage and come in profoundly anemic. She had hematochezia, which is the name given to bloody stools, not melena. That's a little slower bleeding. But this was, every now and again, she just gushed blood. And she was throwing up blood as well. So she was given a couple of pints of blood and taken to endoscopy. They did upper GI endoscopy, lower GI endoscopy. That's all they had then, and they couldn't find any reason for it. So they would transfuse her and send her home. And about every month she'd come back with something akin to that. And finally, after the 3rd try, they said, why don't you follow up in medicine clinic between now and the next bleed? And she did. She came in about 2 weeks after her last discharge. She was on iron, and I looked at her, and her face looked like this. She had these little red spots on her, which when I pressed, disappeared. These are avian anastomoses, called telangiectasia. And she had them, but it hadn't been noticed when she was in hospital because they always examined her when she was profoundly anemic. And she didn't have enough red cells to go and fill telangiectasia. They bleed from the gut because the telangiectasia, the avian anastomoses, can be there too. Now, some of us are used to seeing that in alcoholics. She was not an alcoholic. What she had was a fairly rare, thank goodness, but not all that rare disease called hereditary hemorrhagic telangiectasia, or Osler-Weber-Rondeau. But her physical exam couldn't show it, and her enteroscopy couldn't show it because they were all done when she was markedly depleted of blood. Only after discharge, not having bled in the interval, did she get enough red cells to show the red. And happily that had a therapy which was female hormone. Odd, isn't it? Because estrogen can cause telangiectasia, but this was progesterone. And we made the diagnosis, and she didn't have any more bleeding. I thought that was kind of great. And I just, again, lucked out. She came at a time when the markings showed. I was at the University of Michigan for a short period in the late 70s and early 80s before I came to Davis, and I ran the ICU there, the medical ICU, and I was called because a man had collapsed in the street following a severe headache and was brought to the intensive care unit. And I walked in to see him because obviously something horrible had happened, and he looked like this. And I thought, I've seen him before. I've seen him before. So I asked his family. I said, has he always looked like this? They said, yeah, pretty much. I said, do you have any old photos of him? An old driving license, a passport, any, photos of him, not as a child, but as a man, because I wanted to see if they had changed. Because I had seen this man. Anybody ever see the movie The Princess Bride? Who is that? That's Andre the Giant, and what was wrong with Andre? Why was he a giant? That's right, he was an acromegalic. And I was asking for the old pictures because if I could see the changes in the soft tissues of his face, this area above his brows, which is getting a little puffy, his chin, which is getting larger, and it is soft tissue, because he's producing growth hormone from the pituitary tumor that gives acromegaly. Now, growth hormone also works upon the pituitary itself. It makes it bigger, and it's stuck there in the cella turcica, so as it gets bigger, it can cut off its own blood supply and infarct. It's called pituitary apoplexy. It's preceded by a severe headache, and then you fall down. It's a medical emergency because the pituitary is now destroyed. So we actually treated him for acute Addison's disease. He didn't need any more growth hormone, thank you very much. And then later a little testosterone, and he was fine. But the thing about his changing and his family saying he's always been ugly struck me as an odd family response. I had one more interesting experience with an acromegalic. I didn't put it up. There was a fellow in the grocery store where I was shopping, and he was buying up a lot of deodorant. Acromegaly increases the size of sweat glands, so you get a lot of smelly. And I had an ethical imperative moment. Does a total stranger come up to a guy and say, did you know you had a pituitary tumor? Because that can be very upsetting. And I'm standing in back of him in the checkout line, and I'm thinking, should I tell him that he should go see a doctor? And if I do that, then of course he's going to say why, and I'm going to have to tell him, I think you may have a pituitary tumor. And so I didn't know how to handle it, and finally I just stood behind him and I said, acromegaly? He turned around and said, yeah. Okay. I have loved clinical medicine all my life, but I did have to make a choice for it because there were so many other attractive options, not only amongst the medical specialties. Surgery was kind of out because a lot of the time you're with your patients, they're not talking to you. And that bothered me because I love the interaction with patients. And OB also was too confining. That's mostly women and children. Pediatrics, I like seeing them all. And psychiatry was a possibility, but then the clue part of the physical findings would have been out of my little scenario as to why I wanted to be a doctor. Bench research and clinical research, very intriguing, but again, it's distant to patients. And public health is very important, a good thing, and you can think of reasons for all of your inclinations, and they're all worthy. But I needed patients. I needed them, and was dependent on them for my happiness. It wasn't just the problem solving, it was this extraordinary recognition somewhere really very early, I think as a senior student, that they were my very best teachers ever. And they told me stories that you have to pay to see. and they gave me unparalleled access into their lives. I could ask them questions that other people would be arrested for asking, and it's just extraordinary. And they taught me things. Here's a 65-year-old woman. This was when, very early on, I think I was a resident, and she was dying of metastatic colonic cancer. And every day her family would come to visit her. And they were a large family. She had children and grandchildren and great-grandchildren. You'd think 65, but she had an early marriage. And they would laugh, and they would love her, and she loved their visit. And then they'd all go home, and they'd be back the next day. And one day I came in after the family had left, and this woman, who was absolutely reconciled to her death, was crying and crying and crying. And I asked her, did she need pain medicine? What was it? She said, no, it just occurred to me, something that I hadn't thought of before. My family comes every day, and I know that each of them will mourn my loss when I die. But today, for some reason, it occurred to me that while they'll lose me, I'll lose all of them. I'd never thought of that as one of the great griefs of death. It's a personal apocalypse, the end of the world for her. We're always thinking that people who are afraid of dying are afraid of going to some unknown place. And those who have, for example, no particular religious faith are particularly beset, if only because sort of going to an unknown place. But we all go to unknown places, really. But what she was looking at was the death of everyone she loved. And now, in speaking to dying people, I'm a lot more careful about making assumptions about what they are afraid of, simply because some of them are not afraid for themselves. They are who they have always been. They are afraid for their families, and that they won't be there to care for them. Gypsies. Gypsies is actually a word that the Romani people, who are long ago immigrants from northern India coming up through Europe, don't use. They call themselves Rom or the Romani, and they are clannish. And they admitted a woman to this hospital who was just failing. She was a very large woman. She had shortness of breath and congestive heart failure. And the reason they admitted her was because she was surrounded by all of these people who were looking after her, one of whom was a very large man who said something akin to, she dies, you die. So in she comes to the hospital, and she herself is really kind of semi-comatose, so I didn't get to talk to her much. But the room in which she was placed, it was up on East 8, was just full of other people. And the nurses came and they said, you've got to do something. I said, what is it that I've got to do? They said, you've got to get that family out of there. Not only are they there all the time, day and night, they are adjusting the rate at which her IV is going in. They're interfering with drawing the blood. They want to know exactly what it's for and why they're sticking this needle in. They tried to get a bedside ultrasound or x-ray. They wanted the guy to stay until they had a chance to read the x-ray. And they were just making a mess of nursing care and studies. And about that time, a New York physician who had a very large group of Romani for whom he was caring decided that he'd write a paper about the culture of the Romani. One, very suspicious people of all of us because of how badly they'd been treated in Europe. Many of you know that during the Holocaust, gypsies were also wiped out. And they were considered to be liars and thieves in most places and treated very badly. So they formed a social contract among themselves that said, we will look after each other and we will be very, very careful of all the things people try to do to us because of all the terrible things they've done to us for a long time. And the social imperative and the cultural requirement was that they take care of their own. And by the way, there are no gypsy kings and queens because it's not a monarchy. They made that up. They thought it would impress people. Now the nurses were given by me copies of this paper which described all of these cultural things, and suddenly this woman and her family became very interesting. because now they could match it up with what he had described and understand what was going on. And she taught us all a lot, simply because once you start wondering why things are happening, then they become interesting and entertaining as opposed to obstructive. Now, changing the rate of flow in the IV, that's a different thing. We had to put a lock on it. But in general, I think we did a good job of transforming ourselves into agents that these Romani could trust. Oh, Kiska. HIPAA wasn't existing when Kiska and I were together. I was then a chief resident, I think, at San Francisco General Hospital, so that would have been in the mid-70s, mid-1970s. Kiska was a Finnish sailor. He was a merchant marine. Now, at that time, I was introduced to him because he would come on a regular basis with esophageal variceal bleeding and be brought to the emergency room and then admitted to the ward. The ward was not like ours now. It was a gigantic L, that is a wing of the San Francisco General, and there were about 24 cots on one side, 24 cots on another. Each had a curtain, but that was it. That was the only privacy. And it was largely the destitute and the alcoholic and the drug abusing and the otherwise lost and lonely who came to San Francisco General. Now, Kiska would come in with this terrible bleeding from his ruptured varices, which was the consequence of the fact that he was a very heavy drinker. And then we would have to tamponade the varices, and he was in hepatic coma, and then he would usually wake up. And when he woke up, he was the most entertaining man I ever met. He would tell stories, and all the guys from all these beds would gather around to hear Kiska tell his stories, because he was a merchant marine. And he would go on to the Pacific, and he told us of his trips to Hong Kong where he gambled, and he would tell us of what happened to him in Macau and how he would go down to Singapore to the brothels there and play with the ladies. He told dirty stories, and everybody was entertained. Everybody liked Kiska. And Kiska did this on 3 occasions. Finally, on the 4th occasion, now it was coming towards the end of my year, we had chosen him, and he had recently been admitted again, as the man we were going to present on chairman's rounds. This is something maybe you don't know about, but it used to be the way that the top chair of the Department of Medicine, who was the chairman of medicine at Moffitt Hospital, UCSF, on Parnassus, would come to San Francisco General and round with us. And then we paid a great deal of attention. He was a good teacher and very clever man, but it was largely an entourage following the king. And I went to Kiska because he always called me Cupcake. And I said, Kiska, look, the chairman's coming. I really have to make a really good impression. Could you not call me Cupcake when the chairman's here? And he said, well, what do you want me to call you? And I said, how about Doctor? He said, okay. And so here we come. Here's the chairman, who's 6'4" or something, and all of us following. And I'm walking next to the chairman because we're going to go see Kiska. And we get close to him, and he looks up, and he waves at me. He says, hi, Dr. Cupcake. Kiska. He did as I asked. After his last major bleed in recovery, the guys on the ward, and they also were repeatedly admitted, so they got to know each other fairly well, came to me one day and they said, you know, Kiska looked really bad last time, and we want you to talk to him about his drinking. This is from a whole bunch of still active alcoholics. They said, you know, he's going to kill himself, and we all like him so much. And could you talk to him? So I did. I went over and I said, Kiska, the men have asked me to talk to you, and, you know, I've talked to you about this before, but here we got this whole group. We all love you. We don't want you to die. So you got to stop drinking because you're getting close. As a matter of fact, every time you came in, you were very close. And he said, well, let me think about it, Cupcake. And I came back to him about 6 hours later, and he said, you know, I thought about what you asked about stopping the drinking. And I've decided that life isn't worth living without me drinking in it. And 4 hours later, he was found in the communal bathroom on Ward 45, covered in blood and dead. And I thought, this wonderful man wonderful life, wonderful adventures. And he had as part of his wonderful life and wonderful adventure what to him was a vast pleasure, and for which he was willing to pay the price. And who am I to scold him for that, to tell him how he should have lived and what he should do from now on? Highly intelligent man. And since then, I've always been a bit reluctant to start preaching to people about how to live their lives, because no less than Mark Twain, actually, before Kiska, said, life is not worth living without me smoking, and he lived into his late 80s, as I recall. When I was at the Veterans Hospital, Fort Miley, in San Francisco, I was called to see a man who was just admitted with pancreatic cancer and severe abdominal pain. So I go into a 4-bedroom now, and there are 4 men in it, 3 of whom are really big guys. And then I look at the patient, whose name was Yoshi, and he is a small man with a charming smile and looked different to everybody else. And the reason he looked different was he was Japanese. Now, Japanese soldiers had fought with the United States in the Second War. They're Californian Japanese mostly, and they had gone mostly to Europe. And Yoshi and I were talking. He had an interesting story. After the war and after the surrender of the Japanese, he had stayed in Japan for a little while and then come to America, to San Francisco in specific. And about 5 years before I saw him, he had started having this abdominal pain, and it wouldn't go away. And so he was walking by the hospital, and he saw on it, it said, Veterans Hospital. And he thought to himself, I'm a veteran. So he walked in and told the reception person that he was a veteran of the Second War, and he was having abdominal pain, and she made an appointment for him in the clinic, where he was discovered to have an abdominal mass, and they did a biopsy on it, and it turned out to be adenocarcinoma of the pancreas. And it was not surgically reparable. And that diagnosis was confirmed by the American Air Force Institute of Pathology. So, yeah, he had it. And then they couldn't do anything, so they just let him go, give him some pain pills. Out he'd go back into San Francisco, but he was readmitted frequently because the pain kept reoccurring, and it lasted a long time. Now, I'm hearing this story, and I'm thinking, they did not send Japanese Americans to the Pacific Theater to fight because they would be shot by friendly fire, and they all look alike. So I asked him where he fought, and he said in the Pacific. And the next question was the big one. It was, which army? And he had Japanese. Nobody had asked him before, which army? And now I feel this presence behind me of the other 3 World War II veterans in the ward. And I turn around and they're looming. And I asked them, I said, hi guys, can I help you? They said, yeah. They said, don't tell anybody. Yoshi's our friend. And I thought, isn't that wonderful? They'd all fought. And these 3 men didn't care that it was the other army. And they were protecting him. So I never told anybody. But you. For the first time. But I happen to know he's dead, so he can't be hurt now. Who knows Scott Christensen from Hemonk? Yeah. He was a resident, and we were in clinic, and we heard this ruckus out in the entry waiting room, and went out there to see what was going on. And the receptionist there was facing this extremely menacing-looking man who had the leather jacket and all of the patches on, and he was a biker. And he carried with him a referral from the orthopedics people to be seen in medicine clinic because he had severe back pain. He'd had several motorcycle accidents and fractured a lot of his spine. And she didn't want him to come in because she thought he was scary and something of a criminal. because he rides a motorcycle. Well, Scott and I go out and we're talking to him, and it's a genuine reference from the orthopedist, and all he really needs is somebody to verify his analgesics, his narcotics really, once a month, and to make certain that he sticks to his contract. So we said, come on back. And he was actually a very nice fella. You know, he didn't have any tattooed swastikas or any hate speech on him anywhere, but he was scary. And he was a very accommodating man. He came back regularly every month. He got it. There was no repair other than the narcotics, and he kept his word. About 6 months after Scott and I took him on, for some reason I had a dream, a nightmare. And I was, in my dream, walking from Old Sacramento to the K Street Mall through the tunnel that they have connecting them. And it was dark in there, and it was dark outside. And there was only one lamp in the tunnel with very faint illumination. And I'm looking down the tunnel, and coming towards me is this behemoth, this really large guy who's just a shadow, and I'm thinking, I did a really stupid thing. I'm caught in a tunnel, and there's this person coming at me, and they may be after mugging me or robbing me or murdering me or whatever. And I turned and I tried to run away, but in dreams, you know, sometimes you run real slow and you can't get away. And I looked back to see how close he was, and by now he's standing under the light. And it's my biker. It's my guy from clinic. And I said, oh, thank goodness it's you. I was really scared. He said, come on, I'll walk you to the other side. Good. And so he did. And the next time he came to clinic, I told him the story about him having been, you know, my protector. And he loved it. So, a month after that, from the reception room comes this ruckus again. A new receptionist had been there, I guess pro tem, just for the while. And she said, you're supposed to see Dr. Fitzgerald? He said, yes, I am. I'm the man of her dreams. I loved it. The most touching event here for me was this. In the early 1980s, AIDS was just coming up. It had been first reported in Los Angeles, San Francisco, and New York, and now it was coming to Sacramento, and we were not good with it. The entire division of infectious diseases, except one man, Neil Flynn, refused to see these people. They were afraid it would destroy all of their research, all of their other interests. They'd be overwhelmed. So Neil worked with 2 doctors in the community, and those 3 took care of people with AIDS. We had set aside on East 8 4 rooms, that's 8 beds, for people with AIDS, because at that time we didn't know what caused it. We saw cachectic young people come in, men mostly, and they would have gigantic Kaposi sarcomas, and the worst of the manifestations then was slim disease, this torrential diarrhea that would just empty them. And the fact that they had no visitors. No visitors. Some had family in town, but they didn't want to come to see their sons. They were ashamed for them. Now, in order to set this up, we had to ask the hospital to help us. And they said, well, you can have nurses, but they have to be volunteers. They can't be required of them. And by the way, we'll set up this strict hygienic protocol, including hazmat suits. And so very few people ever went to visit. And they died. And they died fairly quickly, but usually from about 6 weeks from the first symptom to death. This was very early on. And it probably was that they wiped out all of the folks who were susceptible, and thus led to a greater population of people who survived for a long time with the virus, even before therapy. So we're up there, myself and my residents, and we hear a voice behind us saying, where are the boys? And I turned, and there were 3 or 4, I can't quite remember, older women with silver hair, and each of them was clutching a large polystyrofoam cup with a lid on it. And I said, I don't think we have anybody named Du Bois here. She said, no, Du Bois with the bad sickness. And I asked her, I said, are you family? Are you relatives? She said no, and she went on to explain that she and her companions were from the local synagogue, and they were carrying chicken soup in this, and they wanted to go and visit with the boys and give them chicken soup. They were Holocaust survivors. They knew what it was to be thrown away, to be let die, to be killed. And they had formed this organization called the Chicken Soup Group, who would go and feed people who had no one else. And they would spend hours with those men. They would be with them when they died. The chicken soup didn't work, but the humanity certainly did. The patient stories that I've just told you, and the wonder of them, and the generosity of both the patients and people like the ladies from the Chicken Soup Group, melded into related events. Memories of my teachers from medical school on, their trust in me, their infectious enthusiasm. 3 quickies. As a second-year student, another of my classmates and I were assigned to go to the Moffitt Hospital emergency room where nothing big ever happened, because if you were seriously sick, you got taken to Mission Emergency Hospital at UCSF. And there was a woman who came in at 3 in the morning. We were spending the night there watching emergency medicine, which was staffed, by the way, by a single intern. And she came in and she had a breast cyst. And we asked her, we said, "Why'd you come in so late?" She said, "I figured it wouldn't be busy." And then we were to meet with a preceptor at something like 7 in the morning. And down bounces this young guy with gray hair, strangely enough, who goes in to see her. And he's asking her all these questions. And he shows us how to do a breast exam. And then he asks if anybody else in the family has any breast cancer. She said no. And we all thought it was a cyst. Even the wise ones, like the second-year students, who didn't know what we were talking about. And then he asked any other things in the family that we should know about. She said, my mother had thyroid disease. So this young doctor, couldn't have been more than 39, seemed old to us, went on talking about thyroid disease because that was one of his favorite things. That led him to tachycardia, which led him to heart disease and atherosclerosis. And he just went off in all directions. And it suddenly occurred to me that the patient and both of us, the two M2s, were having such a good time. And it wasn't really the content of what he said, but the fact that he was having such a good time. He was infectiously interested. And I caught it. I said, if I can be that happy doing work at 7 in the morning, that's what I want to do. That man was Hibbert Williams, who was the 3rd of the deans of the School of Medicine here at the University of California, and the man who recruited me here. He's been my teacher and my friend now for 45 years, 47 years. I had a patient at San Francisco. It was, again, during the 70s. And in addition to the sit-ins and the love-ins and the rise in venereal disease and drug abuse, there was a strange sort of attitude amongst many of the people that they would try something different. So we were admitted to the ICU, a young woman who was so pale that the minute I saw her, I thought she looks like the Pillsbury Doughboy. I mean, she was absolutely white. Now, at this time, you didn't have the labs because it was the middle of the night. So I drew blood and noticed it was very, very liquid, and went and spun a hematocrit, and her hematocrit was 7. 7! That wasn't her hemoglobin, that was her hematocrit. Normal is 45, 50. In a young woman, maybe 35. 7! And then I looked at it under the microscope because we had to do that too as students. And these were really big red cells. Really big. Didn't have a mean corpuscular volume, but I knew they were really big. So I thought, she is so anemic. That's why she looks like a lump of pastry. And I asked her, I said, "How did you get this?" She said, "I don't know." And I took a history from her, and she was quite comfortable at the time. So it had evidently been going on for a long time. And it turns out that she was on what she called the flapjack diet. She would take flour and add water and mix it up and make a pancake. And she had that as the sole ingredient of her diet for the past year. She was convinced it would make her somehow feel better. Now, it turns out that flour contains no folic acid, none at all. So when we finally did get the hemoglobin back from the lab, by the way, her entry hemoglobin was about 2. The only reason her hematocrit of 6 or 7 was so high was she had really big red blood cells. So I saw that hematocrit and I started to transfuse her. We didn't have packed cells. We had whole blood, pints of whole blood. And I was putting those in here. Now, when I'd seen the cells, by the way, I had called my attending, who happened to be a hematologist. And I was transfusing her second unit, and suddenly she started gasping for breath, and she sat up, and I looked at her, and she was no longer white. She was blue. I had somehow converted a white person into a blue person. And running down the hall, this is now 2 in the morning, was my attending, and he said, "Stop the transfusion," because what this woman had was a chronic anemia that lasted of such a length that she had accommodated to it, and her vascular volume was normal. It wasn't hemorrhage. And I was adding volume to a woman who had obvious problems with oxygenation because she's got so few red cells. And the red cells I was adding were kind of paltry in comparison to what I had to achieve. But what I had achieved was to increase her hemoglobin to 5. And it is 5 that unoxygenated hemoglobin shows blue. This attending, Ralph Wallerstein was his name, he was a famous hematologist, didn't blame me, he didn't beat me up, he didn't call me stupid. He spent the rest of that evening trying to save this woman's life, which he did, and teaching me. And I was so grateful because I almost killed her. And he continued to teach me for all the years we knew one another. And I've always been grateful to him, even after I made a really bad mistake. One more story about Hibbert Williams. He became chief of medicine at San Francisco General. At that time, the emergency room was staffed only by a medical resident and a surgical resident, and the medicine resident saw all the people, the medical people, and the surgeon saw all the surgical people, and it was they who determined who would be admitted and who would not. Now, this was in the late 70s, and at the time, the Public Health Service in San Francisco did a remarkable thing. They ran all the ambulances. There were no private ambulance companies. And every weekend night, so Saturday and Sunday night, they would send out an ambulance that they unkindly called the Boozer Cruiser to pick up people who were on the street, lying in cold on the cement or over grates or tucked into doorways, and they would put them in the ambulance if they looked ill and bring them to the emergency room. And we had a place set aside full of cots. We'd put them to bed, we'd get them blankets, we'd give them a yellow bottle, yellow because it was an IV saline plus B vitamin solution. And in the morning, the cafeteria there would make hot buttered toast, hard-boiled eggs, and coffee, and bring them to the emergency room. And all of these men who had been brought in would be fed, and then they'd go out again. I thought that was an immense act of generosity by the system, by San Francisco. Except there was one old man that didn't go anywhere. He was too tired to eat. He was thin, he was old, he was mildly hypothermic. There was nothing else wrong with him, really, other than this simply sort of couldn't do it anymore. Now, in the mornings, the chief of medicine and the chief of surgery would each round with their resident. And when we came to this old cold man, the resident said, we've got to get him out of here, so maybe we'll give him some more IV or something. And Hibbert Williams, the same fellow who was in the ER with me when I was a second-year student, said, "Admit him." Now, the resident, anybody ever read House of God? Yeah, was the Iron Man. You didn't admit anybody unless they were really, really sick, because you feared that your people upstairs would think, your colleagues in residency would think you were some sort of wuss. And this fellow challenged the chief of medicine. I give him that. And he said, well, why are we admitting him? He said, he's sick. He's old. He's cold. And the fellow said, well, what's the admission diagnosis? And Hibbert said, compassion. God, I love that man. He's 82 now. He's out in Davis working with the community in health prevention. And what these things did for me was that my teachers taught me not just what to know and what to do, but I think what to be, both for other people and for myself, because I wanted to be like them. And there's this line, which is in a really long poem by Wordsworth that I promise you shouldn't read because it'll just bore you to tears. But there's this one line, which is this one: what we have loved, others will love, and we will teach them how. So when you're teaching your students, and you will, it's not how much you know. It's other things, more ephemeral. And in addition to the assigned faculty, or resident to intern, or intern to medical student, it was all of the people who teach you. Colleagues, each other of course, staff, nurses, administrators even, and doctors all over the world. I lucked out. I went to Malaysia on somebody else's dime to study schistosomiasis mannsni in Malaysia. And then I had to go through Singapore and Thailand to get there. Took a little trip to Hong Kong. Then the American College of Medicine sent me to Russia, Mexico, Japan, and Saudi Arabia. And there were other things that happened that got me, again, free flight to England, Scotland, Holland, Chile, Bolivia, Austria, Germany, and the Balkans. And I spent 2 years in the previous Soviet, two swings, not 2 years, never, in the previous Soviet Union and every state of the Union. So that led to the third, and I hope final, fourth maybe, advantage of recognizing how lucky we all are to be doctors, as you all will be. And one was Dr. Cowboy. I met him in Malaysia. He had joined a research group to go to Malaysia to study the effects of Flagyl, then a new drug, on amoebiasis, which was common there. And we worked in a jungle hospital for Aboriginal people who were called the Orang Asli. Orang is the Malay word for man. And there were 4 types of men in Malaysia. The Orang Asli, the original people, who were kind of jungle dwellers. Then there was the Orang Melayu, the Malay. These were the occupiers from 1,000 years ago who had come probably from Indonesia and the archipelago, and maybe India. And then there was the Orang Putih, the white person. That was the British, who had during the Imperium, control of Malaysia. And then the final one, whom I also met, the orangutan, the man of the jungle, the orangutan. I ran into him on the jungle trail once. Very nice, actually, not at all threatening. So, but Dr. Cowboy is what we called the guy who was doing the studies on Flagyl. And Gilman, Bob Gilman is his name. And he was called Dr. Cowboy by the Orang Asli because he was an American, and he reminded them of somebody they'd seen in old westerns. And he was a rough and tough sort of guy, very brusque, very New York. But he adopted me, and he took me, and he taught me. And 45 years later, a Briton who had come here on a clerkship was asking me, do you know anybody who does research on mycobacteria? Because I'm very interested in that. And I said, well, I have this friend Gilman who went into infectious diseases. He's in Peru now. And he said, oh, is he doing studies on mycobacteria? I said, yes, he is. And he said, could you call him and ask him if I could come and study with him? So I did. I called Gilman. 45 years after I met him, he said, send him on down. I'll take care of him. That's nice. When I went to Saudi Arabia, when I went to Pakistan, and this was to help establish a new medical school there, it was shortly after a hijacking of a Pan Am in Karachi, And when I got off the plane, I was warned 6 times by guys with Uzis about a whole bunch of terrorism going on in Karachi, and I should be really careful. So I went to the hotel, spent the night. It was very close to the building of the new hospital, and I was walking toward it, and in the doorway is this extremely tall man in a white coat who's staring at me. And he seemed formidable to me at the time, and he was totally blocking my entry. And I thought, should I run? Is he a terrorist? Is he not like Americans? But I thought I couldn't really shame myself or my school, so I got about 2 feet from him, and he leaned forward and he said, "Do you know Walt Trudeau?" He was a gastroenterologist here with whom he did his fellowship in gastroenterology. And that man wanted to know if that GI professor, who's still working here, by the way, he's in his 80s, was somebody I knew. And now that I knew Walt Trudeau, he took me home with him and his family to supper and took me the next day on a holiday to the Sea of Araby and even paid for a camel ride for me. And I'm thinking, I never met this guy, but I knew somebody that he knew. And that brings up the doctor in the airport, sitting in an airport. I can't remember which one, Chicago, New York, somewhere. And the plane is delayed, so we're chattering together. And we're talking about who knows who and who knows who. And it turns out we all know people who know people. And the plane flight was canceled. And I said, oh, no. Night in the airport. He said, no, this is my city, so you come home with me. And we'll feed you dinner, and then we'll come back in the morning. And I was thinking, that's nice, you know, because if you're in an airport and your flight gets canceled, all you have to do is find another doctor, and they'll take care of you. Now, what I don't remember in much detail from so many years ago are the lectures and texts, and that's as well because it's all different. And I certainly don't remember the technology and procedures of the past because they've all been surpassed now by other things. And the thing I remember least is the right answers on tests. I pity you, because those answers will be wrong at an increasingly rapid pace. PSA, the Women's Health Initiative, estrogens for all postmenopausal women. Then today, by the way, yesterday, they overthrew fats as problematic, said omega-3 fatty acid doesn't work, and you should eat probably butter rather than oleomargarine. Okay. And calcium and vitamin D for everybody, for osteoporosis, all postmenopausal women. Turns out there's increased deposition of calcium in the vascular endothelium. Maybe we ought not to do that. So what is absolutely true today is going to be totally wrong tomorrow. And I wouldn't spend a whole bunch of time on it other than you have to pass tests to get licensed. Too bad. What I would leave you as the last lecture and the last lesson is almost everything you do in whatever field you choose, and it could be in science, or it could be in clinical medicine, or it could be in epidemiology, it could be in any of the specialties or subspecialties. Do it because you love it best. And then try to be the best at what you've chosen. And you'll get all the joy I had, even if your inclinations and gifts are different. There is no best thing to do. And you'll talk to each other, particularly the more junior students, the M1s and M2s, who somehow know exactly what it is you need to do, not having had any experience with it. So don't listen to them. They don't know. Then once you have achieved what it is you love, in whatever means you can, show other people how much you love it. It's good for patients if you choose to be there, because then they're not the bother, they're the joy, and they can feel it. They know that you find them valuable and interesting. And honor your patients and your teachers and your colleagues and students and everybody you work with, unless they are dishonorable. But they'll teach you something, either way. And I have had, in retrospect now, add 20 years on to my midlife crisis. I'm 70. And I'm thinking how lucky I was. how extraordinarily fortunate to have been able to participate in a profession that, whatever you do in it, offers this enormous entry into all of the forms of human experience: tragedy, triumph, joy, despair, fear, courage, belief, all of the things you read here. And that I was given by accident as a child, and I did not know why, a life of kaleidoscopic interest and excitement and joy and even the sorrow. Because without experience all human emotions, you really haven't fully developed as a human being. So even the bad ones are in retrospect worthy. And all of these things that I've got listed here, you pay money to see in movies and on Netflix. And you have it in vivo, in life. And simply remember that, I think. Now, there'll be hard times. It'll be difficult. You'll work very hard. You'll be disappointed in some things and elated by others. But ultimately, at the core, it is got every possibility available in every area available of the human experience. And at the end of your career, if you're lucky, you will have a treasure trove of memories. What you won't remember will be your grades. What you won't remember will be your paycheck. What you will remember are these experiences of the sort that I've given you here. So have them. Have them. And maybe it's discovery, and maybe it's travel, and maybe it's coming up with new ideas of whatever sort, or maybe it's even writing about medicine and the people who populate it, including the patients. But if we used to have a communal dining room, which we don't really have anymore. And I used to watch young docs, and they were always talking about the cases and the facts and what they had just read. And then I was watching the older docs, and they're telling patient stories. And that rich treasure trove of memories and of stories to tell is what will be your greatest reward. That and the fact that people trusted you with their lives.